For the next few minutes, it's my distinct pleasure to walk you through SentiAR's story. So, SentiAR comes from sentir, to feel, AR, augmented reality. The genesis of the technology goes to a very sophisticated team with a lot of acronyms at the end of their names. Chief of them being Dr. Jennifer Silva, who is a practicing electrophysiologist. This was essentially her brainchild. And she asked the question, or made the statement, you know what would be nice? And a lot of good technology starts that way from actual users. And in our case, it was electrophysiology, and that's where we started. You know what would be nice if I can see the heart in my procedures and to see the catheters inside. And you can read it, like really see them, right? That's how a normal person talks. What she was trying to tell us at that time, 7 years ago, is that with the best of technology we have, we still can't see what we want to see. And this is what she's talking about. So the electrophysiology and the specific procedures we're talking about are cardiac ablation procedures, where a 3D map of the heart is created. The sources of erroneous currents have to be identified and ablated so that there's no more erroneous currents. The ablation is delivered through different energy sources, but what you're seeing here is, I went backwards. What you're seeing here, those spheres are where the ablations were. And this is the best they have. They're looking at two 2D views, and they need to create a three-dimensional structure in their mind's eye while they're operating. And if you want to see the room they're operating in, it's quite complicated. There's lots and lots of data coming from very disparate systems, and they have zero control of any of these systems. So they're supposed to quarterback the case with verbal commands and still care for their patient. So this complexity and communication load reduces the efficiency drastically. So what we did is we developed a way where you do not have to be looking at this picture, but rather you can actually be in the procedure in an immersive way. So our vision was to create a fully integrated platform. We started with the hologram. You're seeing here a peek into what's coming next. We're a fully integrated platform. This image isn't created in paint.net or something. It's actually coming from a real study we've done where a physician is delivering ablations using fully virtual screens. If you notice, nothing is on in the background. It's all on our platform. Why is this important, this intuitive control, one source of truth? Why is this digital twin important? This is what the physicians are telling us. This technology is FDA approved and is in use right now. And here's what they're telling us. You cannot understand what it's like until you start using it, how intuitive it is. And the visualization part is just the beginning. We've also given them full control of what they see. And that seems to be creating quite the dynamic for the operating physician. Here's a short video of what this looks like in a real case. So this is a physician operating. This was actually in Good Morning America. But this is a physician operating on a real patient through our platform. He's going to be constantly interact with this map during the case. He's rotating. He's able to go inside the heart anatomy for the first time. This is obviously impossible in a 2D setting. And he's doing all of this dynamically on his own. Everything he's doing is he doesn't have to ask anybody, and he can get whatever view he wants through our patented platform and a patented way to interact with it. And I will share with you what the outcomes look like when you start incorporating a technology like this. One of the things that we've seen is the communication volume and the quality of the communication. It's very high and the quality is very low. And the reason is they're always having to ask somebody to do things for them. It's kind of intuitive. Now, Until recently, I was able to share this data with you publicly, but the abstract is actually approved now to be presented at Heart Rhythm Society, and it's under embargo, unfortunately. So I will let you imagine what you think the results are like for now. I apologize. So leading the witness, it's good, right? It's good. I just can't tell you what it is. And I'm not trying to be coy. Literally, we got a letter saying the data is under embargo. This is what happens when you present at a scientific conference. So we did measure load. We did measure quality. And here's a direct quote that came from one of the physicians that used the system. Now, this study was done in 100 patients. We collected 800 points. So it's a very good representation across multiple centers. It was a 2-center study with 8 physicians that encompasses the full experience breadth from 0 years to 30 years of practice. And they realized they don't need anyone during certain parts of the procedure. And of course, that's very powerful. And here's another video showing what this is like when you're delivering ablations. There's lots and lots being delivered. And in this instance, this physician is constantly looking around this ridge. You see that little bump? It's hard for us to appreciate here because it's still 2D. But they have a full view of the peak and the valley of where they're ablating and where their catheter is. And they're constantly interact with this map. Now, just imagine how much harder this is to ask someone all the time. And try to recreate this in your mind's eye from 2D views. It requires a little bit of imagination because you're not, unfortunately, able to see this as a hologram as you would if you were the physician. So the other thing we looked at is what happens to their ability to navigate to certain target points. And this was another very interesting, remarkable piece of the study. And soon will be public. Yes, surveys, fine. Moving on. A summary of the different pieces they told us. 1, gaps in their ablations. So if you're trying to isolate electrical current within the heart, you want to isolate that. And how do you do that? By destroying these active cells through delivering energy. Now, if you think you've encapsulated the area, but you left gaps and you can't see them, it's not going to isolate. And acutely, you may think that you've done that, but it's not a great feeling when you realize later on that you haven't. And what they're telling us is that they're able to see their gaps on their own for the first time. Because again, remember, before this, someone has to manipulate the image for them. Someone has to move things around so they see what they need to see. Remember that fully integrated screen? We didn't actually force this on the physicians. They told us. They said, hey, this hologram is here. I want to see it. You know what else I want to see? Everything. I don't want to have the boom, this massive equipment in front of me anymore. It's clunky, it's expensive, it blocks the view, and people bump their heads on it. They hurt their shoulders. It turns out it was a huge problem. We actually didn't know when we started, but they told us. They're like, integrate this whole thing. So ultimately, all of this is leading to efficiency, precision, and ultimate physician's choice of what technology they work with. And I'm going to leave you with this final piece of data we learned in our study. It moved case volumes from a competitive system that we weren't integrated with in the study to the system we were integrated with, to the tune of almost 30% of our cases. Significant amount of cases moved, 30 to 40, in 4 months, in 2 rooms, of the 100 that we've done. We do about 1.5 million of these in the US, a lot more globally. The opportunity of what this does to market share and how physicians are responding to it is quite massive. So I'm going to leave you with that. I think there's a panel coming up. I appreciate your time. Thank you, and on to the panel.